Hello and welcome in today's nursing webinar session, and myself Shanti. Today we are going to discuss about immunotherapy and targeted chemotherapy. Soon we will have our expert panelist, who is none other Dr. Nikhil G, who is our Director of Oncology, a Senior Consultant, Medical and Hemato-Oncologist from Yashoda Unit, Somajiguda. Let me also welcome Jisha, who is our Senior Nurse Manager from same unit. I think we'll just talk about until Sir joins. You can share the slide to Jisha. Yes.
Good afternoon. I am Jisha Thomas. Today we will discuss about immunotherapy and targeted chemotherapy. Let us see what is immunity. The immune system is the body's natural defense mechanism against foreign organisms like bacteria, viruses, abnormal cells, and including cancer cells. As you all know, immune system is a complex network of organs. Let us see how immunity will work. It works by stimulating the body immune response to recognize and attack abnormal cancer cells effectively.
So here we all know, yes, Sir has joined us. So we were just discussing. Yes, you can go on. Yes, you can go on, Jisha.
Now we'll discuss what is immunotherapy. It's a type of cancer treatment that utilizes the body's immune system to fight cancer.
So I think Sir has joined, and he will be just telling us shortly what is the role of immunotherapy in the current era of cancer care. Yes, sir, I welcome you, sir, in today's webinar session.
Thank you. Thank you, Ms. Shanti. And hello, everyone. Those who don't know me, my name is Dr. Nikhil. I am the Director of Medical Oncology working at Yashoda Hospital, Hyderabad. And thank you for having me here for today's meeting, which is quite interesting meeting. More about the newer medications in the field of medical oncology. And I think you are going to discuss more about immunotherapies and targeted therapies, what I understand. And as we go through the presentation, I'll be happy to take any questions or any doubts or anything. I think let us. I think I missed few slides, but I think you finish the slides and then we can discuss.
So, yes, sir. Here we would like to, as we were just looking at the definition of immunity and immunotherapy. Here we would like to understand, as you know, the awareness of this topic is not very much known to all the nursing team. So could you please provide your insight into the emergence and significance of these modalities of new treatment in cancer care in short?
So to put the things in perspective, what we know for now that cancer typically is treated by multimodality of therapy, I would say. On one side, we are talking about surgeries. On the other side, we talk about radiations. And all along, all from the time of initial invention of the drugs or discovery of the drugs, almost I would say 6 or 7 decades ago, our main thrust always was all on chemotherapies. And when we talk about chemotherapy, it is more to do with the administration of some medications, either through the IV form or through oral forms, which are nothing but some kind of a strong medications, or you can say toxins, which after ingestion or through IV administration will lead to eventual damage of the cancer cells. And in addition, when you pump these medications in the body, you also will get a lot of adverse effects in this regard. And that is what is called adverse effects or side effects, what not only as patient, but also as doctors, we are very much concerned about.
Yes.
Now, how to improve the outcomes of the patient, and there started the quest for the newer modality of medications. And the initial work was done more in the field of targeted therapy and subsequently in the immunotherapy. Again, to briefly discuss about what targeted therapy is all about. Imagine if there is a cancer cell, let's say in your hand, and there are certain proteins which might be expressed onto the cancer cell.
Yes.
Is there any way we can silence that protein, because that protein would be responsible for the signal which start from the cell surface to the nucleus, and that makes the cell divide rapidly. If you silence that protein by one way or other way, you can actually stop all the intracellular signals, and that will lead to the eventual cancer death, and also inhibits the proliferation and the spread of the cancer, which is the hallmark of a cancer.
Yes.
That is exactly what we call as targeted therapy. And I think there you might have discussed some of the examples of targeted therapy where you use a medication which locks the protein, and the protein eventually silences the entire pathways.
Yes.
So example being like a rituximab, which we know, which is used in the treatment of most of the non-Hodgkin's lymphomas B cell type, which is anti-CD20 protein. So if the cell expresses CD20, this drug is usually used to block that particular protein, and that is how you get responses. Then there is another drug called trastuzumab, or also people know by the name of Herceptin, which blocks a protein called HER2, and that again inhibits the entire sequence of the events. And when the advent of these medications, either alone or in combination, the outcomes of the patient have improved quite substantially. In fact, the cure rates have almost doubled in many diseases. So this is probably all about, I would say, targeted therapy. Now, I gave some examples of injections, but there are equal number of tablet forms which are also available. Like, just to give an example, disease like a chronic myeloid leukemia, which is basically treated with a simple humble tablet in the form of imatinib or nilotinib. And now these tablet patients sometimes take it for decades together, like 1 decade, 2 decades, and patients do so well these days only with a small tablet. So these are, I would say, the real success stories when we talk about the medical oncology is concerned. Do you want me to talk about immunotherapy now, or are we going to discuss first?
We will just go slide by slide, sir. Jisha, you can talk about the indications and then we.
These are the few indications for immunotherapies are bladder cancer, breast cancer, head and neck cancer, and kidney cancer, etc.
So, sir, if we are looking at go to the fifth slide, Jisha, we are looking at the indications. Are these the eligibility criteria for this immunotherapy, or non-onco criteria are also, there are non-onco criteria like, as we were discussing yesterday, like few autoimmune disorder patients like SLE and ulcerative colitis, etc. So we go with this, determining this criteria only for immunotherapies.
Okay, so let me keep the things right in this perspective. For now, the immunotherapy is basically recommended for the cancers and not for non-cancers. I think I will explain that part of it.
Yes.
Here, there are, if you say most of the cancers, there has been a lot of research which has gone for almost all the cancers with the researchers try to understand the role of immunotherapy. So you talk about head and neck cancer, you talk about lung cancer, you talk about gastroesophageal, liver cancer, colon cancer, almost all the cancers, there is a quite a significant role of immunotherapy these days. So this is of course this is a very brief list, but the list is quite long. We talk about melanomas and so on and so forth. Yet, there are certain cancers where it has not shown any benefit also. So one of the classic examples remains some sarcomas. We don't use much immunotherapies there. In patients like ovarian cancer, again, we don't have much recommendation in those patients also. Now, coming to the second point, what you just now mentioned about this ulcerative colitis and autoimmune disease, in fact, the immunotherapies actually can cause these problems. So what typically happens is, just to make students and all the audience understand, that immunotherapies is basically boosting the patient's immunity to such an extent through various, I would say, approaches, that the immune system or immune cells will start attacking the cells in question. Here we talk about the cancer cells, and then you get a response. But when the same immune cells start attacking our normal organs, then we get side effects, and that is where what we call an autoimmune disorder. So whenever there is an autoimmune disorder, we don't use immunotherapies. That is a very basic understanding, because you can actually flare the patient's arthritis. You can make the patient's life extremely difficult with the use of. The patient has an ulcerative colitis, and if I give immunotherapy, his ulcerative colitis might go from bad to worse. Or for a rheumatoid arthritis, already the patient's immune system is too high, and then you also boost it further. You are making life very difficult for the patient. So that is considered one of the contraindications as far as possible, not to use immunotherapy for patient with significant autoimmune disorder. And when you talk about SL, you talk about ulcerative colitis, Crohn's disease, rheumatoid arthritis, ankylosing spondylitis. The list is quite long. In general, we don't use immunotherapy because the way it works.
Yes.
I hope I made my point clear over here.
Yes, yes. Yeah, over to you, Jisha, for the maybe. Yeah.
Now let's discuss the immunotherapy drugs. Checkpoint inhibitors are type of immunotherapy that blocks different checkpoint proteins. It is cytotoxic T lymphocytic associated protein. As Sir said, these are the common medications we will use. You can check in the image. And these drugs are high in nature, so always the nurses should check before the administration, and also it should be diluted.
So while handling this CPI, sir, for one more aspects of IT, any other nursing precautions you want the nurses to take? Because this is all high alert medications.
So in general, I'm sure most of the nurses are very well equipped with the knowledge to give chemotherapies. And again, learning how to infuse immunotherapy. We probably may not reinvent the wheel all the time. Most of the time, the principles remain same. As you understand the name of the drugs, like here you have given a couple of antibodies like nivolumab or pembrolizumab, where we ensure that the cold chains are maintained for the as the drug is carried. Important to understand that we have already mentioned that all these immune checkpoint inhibitors or immunotherapies, what we are currently discussing, they can cause a lot of reactions. So as I mentioned, like happens with the most of the targeted therapies, antibodies, here also you might get sometimes severe allergic reactions called anaphylaxis and all that. So it's always one should be prepared with all those your crash card to be ready all the time, and that is quite important. Many a times you probably would know that as oncologists we use a lot of steroids as pre-medications to prevent nausea and vomiting. Dexamethasone is something is a part and parcel of all our anti-emetic therapies. But when we use immunotherapy, we usually avoid high doses of steroids, and usually they are not recommended. So inadvertently, if some doctor writes dexamethasone full dose and immunotherapy in the same thing, it is probably not the right prescription, and these two can negate each other's effects. As you know, dexamethasone reduces immunity, and here we want to push the immunity. So typically, it's probably a wastage of resources when you do that. So that is always remember that it's like it's not like patient comes with the chemotherapy and immunotherapy, and you are going to give pylonocetron or ondansetron and dexamethasone all that. So do not make those errors over here. Always doctors will not write these drugs very specifically. They normally avoid steroids, although there are very specific recommendations how to use steroids when the patient is on immunotherapy. That would be beyond today's discussion. So that is another thing. So one is look for all the allergic history. Always check patient for all allergic histories. Any systemic history. Always it is good. It's always good. I would say step to really check all the vitals of the patient, like what we normally do for all our patients. Document it. Especially during the first dose, you have to document pre, during, and post. And you have to also have to document how the entire treatment sequence has gone for that patient. And once the patient comes back, it is again doctor's responsibility to check and document all these where the issues what the patient faced in the first dose or second dose. Many a times the immunotherapy side effects are quite delayed. So you may not see in the initial part first 3 months, and then all of a sudden you start getting some side effects. So we always keep a vigilant eye on our patients. just to ensure that they are not coming or they are not suffering from any new adverse effects.
Yes.
Any new complaint, many times the patient may not, sometimes they forget to tell the doctor, but most of the time in the wards, they are with our nursing care, and sometimes they are very, very much open to that discussion with nurses. So anything which they can find untoward happening to towards our patient, I think nurses can always bring us back to our notice, and that will actually be useful for our patients
Yes.
in terms of their managing their adverse effects.
Yes. Yes, Jisha.
Let us see what is target chemotherapy. Targeted chemotherapy is a type of treatment that uses drugs or other substances to target specific molecules that cancer cell need to survive or spread. Like some classification that antibody drug conjugate, it's a type of treatment and management for the cancer patient.
Sir, as you were mentioning, these drugs are only, to be, this drug only targets the unhealthy cells, and it is very accurate treatment. Depends on the whatever the cancer the patient may come with to you. So the patient should also go with the radiation therapy and other chemotherapies along with this target chemotherapy in the long go, sir.
Probably I'm not too sure whether I understood your question, but I just put the things in perspective just just to make the audience understand what is ADC, or also called as targeted chemotherapy. As we understand, normally we use those drugs like chemotherapy, like taxanes or platinums, as a separate drug. Here, what basically we do is we take the antibodies, like let us say that as we already discussed about antibody like a trastuzumab.
Yes.
In that trastuzumab, if you attach a chemical or chemical structure, so the typical same target will hit HER2, then it will be internalized, that entire protein will be internalized inside the cell. And post that, the chemicals which are that, which is shown in the this pink star, will, that is called as a payload or chemotherapy payload, will be delivered inside the cell directly. So this is not against the T cells, this is against cancer cells. So if you hit the cancer cells, the drug is delivered inside the cancer cell and the cells get destroyed, and that is how you get responses. And as we understand, the smaller the tumor size, the lesser the volume of the disease, the longer the patient usually survives because of better organ functions, and that is very typical of that. So that is how these particular drugs are usually used. I think I have cleared your point. Any
Yes.
question on this particular point?
Yes, sir. Well, as you said, like payload and how these drugs work for the, cancerous cell. Yes.
These are few specific indications for targeted chemotherapy: breast cancer, colorectal cancer, lung cancer, leukemias, and lymphomas.
Yes, the list is quite long, but I think these are quite important indications where we use mostly targeted therapies. When you talk about targeted chemotherapies, the majority of the work for now is being done in the field of breast cancer. Although I would agree that there is a bit of work which is also happening in the leukemia as well as lymphoma. But when you look at the markets, which are the drugs which are currently available with us, the drug which is known as trastuzumab emtansine, which is against drug which is against HER2 positive breast cancer, also known as TDM1. Many of you might be knowing it by the name of Kadcyla or Ujvira. These are the typical breast cancer drug, which is basically ADC, antibody drug conjugate. As you know, TDM1 or trastuzumab emtansine, the emtansine is the payload over here. The trastuzumab hooks onto the cell and emtansine gets released, and emtansine causes the cell death. And so, in addition to trastuzumab, so here is a more of a double attack for the patient. There is another drug called trastuzumab deruxtecan, which is again recently launched in India last month. There's also quite a mighty powerful drug when you talk about the HER2 positive breast cancer.
Yes.
And outcomes are quite phenomenal. Of course, it's early days for us, but when you look at the data from the trials, we are quite excited to use this drug. We already started on a couple of patients. And this is again similar what we discussed in the previous cartoon, where the medicine basically gets internalized, the target with chemo both get internalized, and eventually the deruxtecan gets released, and that is eventually leads to subsequent intense killing of the cells and without much adverse effects. So this is how normally these drugs are utilized. And I'm sure the further with advances, we'll have more and more drugs in this thing.
These are the targeted chemotherapy drugs we usually use. Rituximab injection. It's a type of targeted cancer drug called a monoclonal antibody. It targets protein on the surface of the cancer cells.
We have discussed already about rituximab, which is an anti-CD20 antibody. And here, what I would like to correct it over here, it is not a targeted chemotherapy. It is a targeted therapy. There is a difference. Targeted chemotherapy is the previous examples what I had given, like a TDM1 or which has got a chemotherapy, some agent inside it. Yes, no chemotherapy. It's only a plain protein. It just needs to hook onto the cell. That's the reason. If you look at the protocols like R-CHOP, the CHOP is a chemotherapy which is given as a separate drugs, and target is given as a separate drug. So that is called R-CHOP. You don't need, and in the previous example, they both are incorporated in one particular medication. So that's a cardinal difference between what is called targeted therapy, like rituximab, and targeted chemotherapy, which is more like a TDM1, or I would say deruxtecan or sacituzumab govitecan, and there are a long list of medications over it.
The initial assessment by clinician includes history and complaints of the patient, imaging, blood tests like CBP or creatinine, and check all vital parameters of the patient and also body weight of the patient.
Yes, yes, I think that is quite important. Now, this is not only important for immunotherapy, but in general for all the patients. But in addition to immunotherapy, we normally, in addition to history, physical examination, and everything, imaging is not something. Imaging is anyway done. Being a cancer patient, most of the patients will have some imaging in place. But in general, we also look for the organ functions. As we already discussed that these patients are prone for a lot of autoimmune diseases. And there are certain examples like hypothyroidism, which can be autoimmune, which can be drug induced. If you start on immunotherapy patients, the thyroid levels keep on dropping. Now, whether that is due to the drug or it was there before the initiation of therapy should be documented. And that's one of the reasons why there are certain parameters which are done from the endocrinology side, just to ensure that all the parameters are in place. Lung functions are checked, the cardiac functions are checked, so that the patient has all those parameters which are reasonably normal before you embark on treatment for immunotherapy. And you also serially follow the patients over a period of time. Because as we have mentioned, immunotherapy can attack any organ, not only on cancer cells, but due to its autoimmune behavior, it can affect the lungs, it can affect the heart, it can affect the joints, it can affect pituitary, thyroid, colon, and all the organs. So depending upon the kind of symptom the patient is showing, we start investigating the patient. The patient is suddenly comes up with an intense cough, which was probably not there beforehand. We immediately suspect that the patient probably is getting autoimmune pneumonitis. So we immediately scan the patient. Sometimes we require to rule out any infections also, and then sometimes we take a small punch of the lung just to ensure that whether patient we are dealing with some kind of autoimmune pneumonitis like picture. So there are ways to do that, but first and foremost is it's very important is to educate ourselves that immunotherapy can work on all the areas, and anything which happens with the patient during the treatment, when the patient is only on immunotherapy, a standard understanding is unless put otherwise, it's a immunotherapy side effect. So one has to be extremely watchful, and history is quite important. So every time patient comes, there should be some kind of a chart which you can mechanically tick mark. Okay, do you have any breathlessness? Do you have any GI upset? Do you have any feeling of extreme fatigue? And then you can make out, okay, we are looking at certain things and certain investigations need to be done in this regard. And because on one side, these drugs might work very well for patients, many patients, if not all patients. At the same time, we don't want the patient to be harmed due to side effects or because of our lack of knowledge about how to handle the side effects. Because as oncologists or as oncology nursing, we are quite well trained or attuned to handle the chemotherapy, but not the immunotherapy.
Yes, exactly. Yes. So Jisha will be just time out. You can just, sir, is there any age criteria for immunotherapies? I think maybe there is a pediatric group also who is, who are also the criteria for IT.
So most of the times, if you see most of the adult studies, the criteria cutoff is around 18 years, where we most of the time we use it. Having said that, the data is also significantly emerging in the pediatric population also.
Yes.
It yet to be more and will get more and more robust data, but there are certain diseases like a relapsed Hodgkin's lymphoma where it can be used. There are mg per kg doses which are also available for the immunotherapy, which can be considered on case-to-case basis when the patient is less than 18 years of age. But if you look at the strict standard criteria for the clinical trials for adult, me being an adult medical oncologist, I can speak more about it. Anyone above 18 is something which we are already sure that we are going to use it. Less than 17, then it all depends on what is the criticality of the situation, what is the data in that regard, and we take a call accordingly. But that has been the trial recommendation to use immunotherapies. Having said that, even so for some pediatrics like relapsed Hodgkin's lymphomas, where we are hitting the fag end of the treatments and we are looking for more and more options, there are treatments which these treatments have been utilized for the patient.
Exactly. Yeah, Jisha, you can go.
Let us check the nursing assessment and care. Nursing care should focus towards monitoring and patient during and the post transfusions. Few checks like selection of IV site, flushing the lines, continuous vital monitoring, and medication always we must check.
You can go as sir has already discussed and.
These are the open communication with the doctors. The nurses should always notify significant changes in the vitals or any shortness of breath for the patient or any worsening symptoms like rashes or delayed infusion reactions like chills, fever or chest pain or any deviations in the blood test.
Any other potential early warning signs, sir? If at all, the nurses should always escalate to you or your team.
So again, a simple rule of thumb is just to anything which you see abnormal in the patient, do whatever. So it's not like when you always are keenly looking only for breathlessness and you miss on to the rash. Always ask patient. When you, especially if this happens with the first dose, so one has to be very careful. Although it can happen anytime, but the possibility is slightly higher because they are all monoclonal antibodies. They are proteins, and proteins can cause allergic reactions. And any patient who is feeling something is feeling unwell, the first and foremost is to stop, inform the doctor, and then you need to always check the vital signs. And then I'm sure most of the nurses are very well trained to handle these situations, including the doctors, and take appropriate call. If the patient getting significant infusion reactions, then it's always good. The onus eventually lies on the doctors what to do about this patient, because on one side we are looking for potential benefit of the drug, on one side we are looking for some kind of adverse reactions. So many times we stop for sometimes we treat with some anti-allergic medications and see whether the infusion goes well. The patient gets another bout of reaction. Usually you abort the entire sequence of the treatments.
Yes.
These are the potential drawbacks, the temporary GI issues like diarrhea, nausea, vomiting, and abdominal pain. And also there may be a fatigue.
I think these potential side effects are just temporary for the temporary period of time, sir.
So we have discussed it. We may not call it as a drawbacks, but we can call it as adverse effects.
Yes.
And adverse effects, as we have mentioned, you just imagine a human body from top to bottom, and every potential area which can get involved or which can get affected due to immunotherapy. Although you have mentioned few over here in the form of GI side effects, but you can imagine what happens when there are lung side effects like cough and breathlessness. When you get brain, it can be encephalitis, meningitis, it can be a hypophysitis, means a pituitary gland inflammation.
Yes.
It can also lead to thyroiditis, which is the autoimmune thyroid phenomena. And I mean, the list is quite long. It's something which we just, and that is something I have a couple of slides I can share if somebody is interested to. But technically speaking, you should, any symptom patient tells you, you
should.
inform doctor, and I'm sure the doctors probably would like to investigate whether it's just passing pain. Many times the patient with a knee joint pain. Now we are also sometimes considering like arthritis, arthritis or some non-specific thing. So many times we do. We may require some tests, or sometimes we just need to keep the patient under close observation, just to ensure it is drug related or non-specific, or the patient had an injury. So history plays quite an important role in terms of the understanding why this patient's suffering at that point in time.
Yes.
The duration of treatment is based on treatment response, disease progression, or tolerability of the patient.
Okay, you can go.
Yeah, I'll just briefly discuss about the duration. We have few patients, our nursing team might confirm the same thing, that we have patients who are taking for years together immunotherapy. Why? Because they present a very advanced disease. They went into near complete response, and they are getting medicines as a support also. So some company supports, pharma company support. There are no side effects. Patient is surviving without a disease. So most of the studies are done in the advanced setting, which is around 2 years. Sometimes there are cutoffs for certain diseases like a 1 year for a lung in the advanced in the locally advanced setting. So there are either certain criteria where we stop after that 1 year cutoff. In an advanced disease, if the patient is doing well, there are no significant adverse effects. In that case, there is no upper limit. So patients might take it for years together. If you look at certain patients from various other countries, patients have been doing for 7, 8 years, despite being stage 4, because the immunotherapy is working so well for those patients.
Yes.
Patients are also hesitant to come off, so are the doctors, because when the things are too good, then nobody wants to break that harmony.
Yes.
Role of diet to strengthen the immunity. Patient should be educated for adequate hydration always. Encourage the patient to eat balanced diet, more focus on protein-rich food to regain immunity function, and avoid outside food, and it may rise to foodborne illness like nausea, vomiting, diarrhea. And also we have to infection-free measures, like we need to explain the patient all the infection-free measures like hand washing, wearing mask, avoid eating raw foods, or avoiding crowd places, etc. This is very, very important for the patient. And also educate the regular follow-ups.
Yes. So I think next slide again you can share, and we have come to the end of the discussion, which is again in nutshell, evolving advancements and clinical guidance in cancer care by onco experts like Sir and the group of oncologists presents a groundbreaking support and will undoubtedly pay the way further. And we always say that early detection is the cure to everything. Seeking medical assistance is crucial for early detection of cancer and cure. So having said so, any conclusion note you would like to provide to the common or healthcare professionals as well, sir?
So I think one of the important lessons for oncologists or all the stakeholders of the oncology is to keep themselves updated and abreast with all the new knowledge. The reason is this is quite rapidly evolving branch of as far as the medicine is concerned, and the principles what we have understood or what we have learned for, let's say, for chemos may not be applied for targets, and the same principles may not be applied for immunotherapies. We are living in the era where there's a constant evolution which is going on. So for us, we need to be always be ready to learn new things, and in a quick way, and at the same time also be ready to apply to the patient, so that the patient is not harmed in any ways, and that can also help us in getting the maximum survival for the patient. So that is how I look at it. I think the presentation was quite comprehensive. What I think we did discuss some important points over here.
Yes.
And there are plethora of treatments which are in the pipeline. So I must tell you, even sometimes for an oncologist, it is quite challenging to read almost on day-to-day basis to know newer medications. Every new medication is, you have to read their studies, you have to read the adverse effect, dosing, short-term complication, long-term complication, educate their team. It's a quite a long exercise, but as long as when the patient is at the center of all the thought process, I think the efforts are usually done, put in the right direction. And that is what my humble request to all the nursing care who are involved in the oncology management. And be prepared to read, be prepared to ask your doctors about any doubts. And you will be happier in terms of learning new things. And the entire, I would say, the treatment administration and patient care will be extremely satisfying for everyone in that regard.
So it was very productive session and great insight which is provided by you, sir. And thank you so much for sharing this platform. Thank you, Jisha, and we end the session. Thank you.
Thank you so much. Thank you.